All right, guys, we're going to be on the video today, so let's try to keep it as clean as we can. Okay?
So I'm going to have you where you're standing, and then some of the boards you're not going to read too well. So
What's that?
I'm going to have you where you're standing, and the board and the shot, because the font's so small, you're going to read the board too well.
I got it right here.
Well, for the people that are watching.
They're not going to be able to read it, you said. All right. All right, let's get started. Let's get the door closed. All right, how we doing this morning? Tired? Exhausted. But we got to do this. We came to do business, right? Remember the new saying. What's the new saying? The new saying is, fear is a reaction. Dedication is a what? Choice. Okay? So if we're dedicated to nursing, there should be no what? Very good. All right, so I sent everybody the PDFs through Canvas. If you look in Canvas, you got them all. They come with questions, and there's answer sheets for the questions as well. So I advise everyone after today's lecture, you go try to take the questions straight up to see how well you do on them. There will be a test on Friday. It doesn't count. So I see the neck snaps. Okay. It doesn't count, but it does count. It does count. I'm going to be straight up honest with you because that's what type of person I am. I don't think we're 100%. Everybody knows where you are, but I don't think, if somebody were to ask me, what do you think about the class, this whole entire class? We're not at 100%. I think if we take this seriously, we could be 100%, but if we don't take this seriously, no, we're not. Okay, so I advise you to take it serious. All cell phones need to be in the slots. Okay. What's that? A laptop. All right, anybody else need a laptop? Just one? Nobody else needs a laptop before I go get a laptop. All right. So put your cell phones up here, please. 2. This is. Feel prepared. But did you hear the part where I said, does anybody, I didn't see you. One more. Anybody else need a laptop? Last call. All right. I ain't going again. Tomorrow, we're going to get started right on the dime at 8 o'clock. Okay? So make sure you're here in plenty of time. And if you come and you need something, that you get it before 8 o'clock so we can start at 8 o'clock. Because we got a lot of material to cover. All right, so this is called Basic Care and Comfort. This is the NCLEX blueprint. It's like the outline of the things that you're expected to know when you go take the NCLEX. It starts out, you can do any manual you want, but we're going to start out with basic care and comfort and nutrition. All right, so we're not going to go through the whole thing like item by item. We wouldn't have the time. We'd be in one manual the whole probably week. Okay, so we're going to address the key areas. Does everybody understand the body mass index and how to figure it out? because it tells you here, measure the client's height and weight and calculate the body mass index. And it gives you an example of how to do that. So if a client weighs 75 kilograms, which is 166 pounds, and they're 1.8 meters, which is the equivalent to 5 feet 9 inches, you're supposed to do the weight in kilograms times the height and meters squared, and that comes up with that BMI. An easier way to do it is to keep the weight in pounds, multiply by the height in inches squared, and then divide the height in inches squared into the weight in pounds, and then multiply by 703. You got to remember that number. But that's also an easy way to do it. Remember the BMI, anything under 19 and a half means what? Do I need my... Anything under 19 and a half means what? Malnourished. Okay, malnourished. Okay, ideal BMI is between what and what? 20 to 25. 20 to 25, not 25 to 30. 25 to 30 is considered what? Obese. Okay, overweight actually, not obese, overweight, correct. Okay, 30 to 40 would be what? And anything over 40 is considered what? Morbidly obese. So I guess we got to start it from the top because only 3 people know it. Okay, anything under 19 and a half is what? 20 to 25. 25 to 30. 30 to 40. Anything over 40. Everybody got that? Okay, what's the easy way I taught you to do the BMI? Multiply the height in inches squared, right? And then divide the height in inches squared after you multiply into the weight, right? And then times it by what number? 703. 703, not no point, just 703. Say it again, we didn't get it. Keep the weight in pounds. Excellent. And then divide it into the weight in pounds and multiply by what? 703. What are the 6 main nutrients? Let's go here. The 6 main nutrients. Protein's one. Come on, guys. Some of you guys are going to be taking your NCLEX this early in the morning. You know that, right? If you go into the NCLEX with this type of character or emotion, guess what's going to happen? Guess what's going to happen? You're not going to be able to use your brain the way you're supposed to. You got to wake it up. Okay, what's the first nutrient that the body uses and the brain loves? Carbohydrates. Carbs. When carbs are not available, what does it go to next? Fat. When the fats aren't available, what does it go to next? Protein. Okay, and then what does it need to move all of the elements in the body? What propels all of the elements in the body? And you're made up, correct. Number 4. And then what's responsible for speeding up or accelerating the chemical reactions? The minerals, the vitamins. Those are your 6 essential nutrients. Let's start from the top. 1, 2, 3, 4, 5, 6. Vitamins, right? Minerals, vitamins, minerals, water, carb, fat, protein. How many kcals, kilocalories per gram for carbohydrates? Oh, wow. 4. Which other nutrient also has 4? Proteins. Proteins. A car full of pros. Most cars seat how many people? 4. So if you have a car full of pros, how many kilocalories are there? 4. Okay? Now, how many does fat have? 9. 9 kilocalories per gram is in what? How many are in proteins and carbs? How many are in fats? What are the 2 types of carbs? See, our nutrition is kind of not there, right? You got to have the nutrition. You got simple carbs and you got complex carbs, right? Simple and complex. And you need to know that. Why, RNs? Why does an RN need to know that? If you have a diabetic with a low sugar, which one of those types of carbs are you supposed to give? Simple or complex? Which one? Simple. Because you want the sugar to peak in what? 15 minutes. So you give a simple carbohydrate. The 15-15 rule. This is why you need to know this. You give them a carbohydrate, a simple carb, and then what do? Wait 15 minutes, and then do what? Check the sugar again. If the sugar's still low, what do? Another 15 grams. And then what if you check the sugar and the sugar's within limits? Complex carb or a protein. At that point, you give them a what? Complex carb or a protein. Say it again. See, this was fun and like I put on this outfit here to give you a good laugh. I hope that did that for you. But what's the reality of the situation? In order to put a uniform on like this, what do you got to know? You got to know how to be a what? A soldier. Do you understand that? To wear this uniform, you got to know how to be a what? To wear that uniform, what do you need to know how to be? A nurse. You need to know how to be a nurse. And the only way you can learn how to be a nurse is to learn from a nurse or learn from nurses. Do you understand that? And there's some things that we are already nurses that we don't play with. You don't play around with certain things. Diabetes, hypoglycemia, you don't play around with that. You got to know what to do. Do you guys understand that? It's not something that you can sit there and go, all right, hold on a minute. What do I do now? Per the board, that's something basic that when you hit the floor, you should know the signs and symptoms of hypoglycemia and what to do if the sugar drops. Do you understand that? You're expected to know that no matter what floor they put you on. You know how they tell you if you go to a floor and you don't know what you're doing, what are you supposed to do? Go to the supervisor. Supervisor is supposed to give you something that you should be able to do no matter your background. Is that one of those things? Question.
When we use the complex carbs, if it does go back to like a normal level, how much? Like, you know how you said 15 for the simple?
15 grams.
How much would it be for the complex?
It doesn't really matter, just something to sustain it. So if you gave 4 ounces of juice, which was complex, then when you go to give another 4 or 8 ounces of a complex carb. Okay? All right, so do we understand what to do and why we need to know the 6 major why do we need to know water? Why do we need to know water? We talked about the carb, why we need to know carbs. Why do we need to know fats? Why do we need to know proteins? Why do we need to know water? What happens if you have no fat? Okay, what else? Can you insulate your body and regulate temperature? Who do you know what population doesn't have much body fat and can't insulate their temperature? And children. What about newborns? What about newborns? Is fat important for them? Okay, what about proteins? What do we know about that? Okay, so they build the tissue in the body, right? What are the 2 types of proteins? Complete and incomplete, right? What does that mean, complete and incomplete? Complete proteins have all the essential amino acids, so we can build all the protein we need. Incomplete does not. What population do you know that eats a lot of incomplete proteins? Vegetarians. That's why you got to know that. Do you understand that? Very, very important. Where's the protein found that vegetarians are usually lacking because they don't eat it? Meat. And those B vitamins are absent. Do you understand that? B vitamins are absent. They affect what system? The nervous system. They also affect the production of what? Red blood cells. Do you need B vitamins for red blood cells? B12, B6. Do we know those? Do we know our vitamin? What are our two types of vitamins? Fat soluble and water soluble. And what do we need to know about those two? What's the difference? What do we need to know? Give me something. Fat soluble, water soluble. What do we need to know? We don't know that the body can only store fat soluble, but it can't store water soluble. We don't know that. What are the fat soluble vitamins? A, D, E, and K. And just A, vitamin A, what do we need it for? Vision. Okay. Specifically, what type of vision? Night vision?
Oh, yeah.
Night vision, right? What's the name? What are the names you may see for vitamin A? Retinol is one. And what's the other one? What's the other form of vitamin A? Look it up. You got computers right in front of you. What's the other form of vitamin A? This is important to know. I'm going to tell you why in a minute. Unless you could tell me. What is the other form of vitamin A? Beta carotene. And guess what? The difference is when you give retinol, you're adding vitamin A directly to the body. When you give beta carotene, you're influencing the body to create more vitamin A. So when you give beta carotene, it's safer, especially for a pregnant woman, because a pregnant woman has to be concerned with the amount of vitamin A that she's consuming during pregnancy because it's teratogenic. Do you understand that? You ever heard of Accutane, the med that they use to treat acne? That has what in it? Retinol, which is what? Vitamin A, which is teratogenic. So you can't become pregnant while you're on the med, and you can't become pregnant after 3 months of stopping the med. It's very important. So if you're concerned about too much vitamin A, which form of vitamin A would you give? Beta carotene. You see why you would want to know that? Is that important? Very good. See, now we're on the same page. We're getting comfortable. We're getting into it. But see, you got to set, this is the same thing when you go take your NCLEX. You got to set this type of, this is the mood you got to set for yourself. You can't go in there discombobulated. Do you understand that? You got to go in there focused, stern, serious, to the point. I came in here to handle business. Do we understand that? And guess what? That reaction ain't taking place, is it? Do you see that reaction? What's that reaction I taught you about this morning? Fear. Do you see fear up here? Why? Why do you not see fear up here? Because I don't have time to do that. Do you understand that? That's not going to do you any good, is it? If I'm afraid, will it do you any good? And you need to think the same thing when you sit in front of that computer. If you're afraid, is that going to do your family any good? Is that going to do you any good? Then face it head on. Do you understand that? Think. Open your mind and just think. You've been taught all of these things through the whole program. You just got to recall them. You got to recall them. That's all. That's all it is a test. Do you understand that? If you give 110%, who cares what the result is? I don't. If you give 110%, that's all you have to give. Do you understand that? All right, very good. What about vitamin D? Vitamin D is next. We said A. You know, it helps with the immune system as well, right? And cell membrane stability. But what about vitamin D? Close. Calcium and phosphorus. Without calcium, you can't absorb what or what? Huh? I mean, without vitamin D, you can't absorb what? Calcium or phosphorus. Without adequate vitamin D, you cannot absorb what or what? Everybody got that? And children, what is the condition where they lack the vitamin D called? And adults, what is it called? What? Osteomalacia. Very good. A softening of the bone. Malacia means soft. Do we understand that? Okay. Let's go to vitamin E. What are we talking about? Guys, you have computers. Be on it. You can either pull this up and scroll ahead of me, or you can pull your textbook up or something. You need to be answering these questions, not me. I need to be explaining them to make sense of them, but not answering them. Do we understand the difference? Vitamin E, what are we talking about? Immune system. Immune system. It deals with the, what do we call them? The troublemakers. What are the troublemakers in the body that cause havoc in the body? What are they called? Free radicals, right? It helps deal with the what? And gives immune system support, right? It's good for the skin, right? What about vitamin K? What about vitamin K? I ain't here. Bleeding. Bleeding. Okay? We need vitamin K in order to what? To clot. We need vitamin K in order to what? Vitamin K is also the antidote to what? Okay? What's the antidote to heparin? Very good. See, look, come on. We're going to be talking about this. We're going to be talking about that. We're going to be talking about this. And we're going to be talking about what? So do we understand the fat-soluble vitamins? Is there a danger of vitamin toxicity with the fat-soluble vitamins? Yeah, because your body does what? Stores them. Now, let's get into the B's and the C's. Let's get into the B's and the C's. What is vitamin B1 called? Thiamine. Thiamine. What is vitamin B1 called? What is vitamin B2 called? Riboflavin. What is vitamin B3 called? Niacin. What is vitamin B6 called? Pyridoxine. What is vitamin B9 called? Pantothenic acid, somebody said? Who said that? Very good. And then what is vitamin B12 called? Cyanocobalamin. Hold on a minute. Vitamin B1 is called what? Vitamin B2 is called what? Vitamin B3 is called what? Vitamin B6 is called what? Pyridoxine. Vitamin B9 is called what? Pantothenic acid. Folic acid. Don't you learn about that in maternity? Shouldn't that be important? How many months is a pregnancy usually? 9. It's usually 9. Okay? 3 months, right? Per trimester, right? How many trimesters are there? So 3 times 3 is? And what is the name of the vitamin that they want you to know for pregnancy to prevent neural tube defects? And folic acid is a derivative of what? Pantothenic acid. And what is vitamin B12? Cyanocobalamin. So deficiency in vitamin B1 leads to what? Berry. What is berry? What is berry? What is berry? Well, it depends on which type you have, right? There's a wet and a dry. And the wet basically causes heart failure. And the dry affects the nervous system. And that's where the Wernicke's encephalopathy comes in, right? Huh? Wernicke's-Korsakoff syndrome, basically, is what they call it. The Wernicke's affects the brain, and the Korsakoff's causes psychosis. Do you understand that? Who's most susceptible to that vitamin B1 deficiency? Alcoholics. What is the name of the condition that they can develop? Berry. What are the two flavors of berry? Which one affects the heart? Which one affects the nervous system? How does it affect the nervous system? Wernicke-Korsakoff's. Are you getting this? Are you understanding this? Lack of vitamin B1 leads to what condition? Berry. What are the two types of berry? Which one affects the heart? Which one affects the nervous system? What are the two types of conditions that you can have that affect the nervous system? Wernicke's-Korsakoff. And what's the difference between Wernicke's and Wernicke's-Korsakoff? Causes psychosis. Very good. And what vitamin are we talking about? And vitamin B1 is called what? Vitamin B2, what is that called? Riboflavin. Okay, vitamin B3, what is that called? Lack of vitamin B3 leads to what condition? Pellagra. Let's look up pellagra. What is pellagra? What is pellagra?
It's a deficiency of vitamin niacin, characterized by the 4Ds:
What are the 4Ds?
dermatitis, diarrhea, dementia, and in some cases death.
Dermatitis, diarrhea, dementia, and death. Are you pulling my pellagra? Huh? Are you pulling my what? I hope you're not pulling my what? I hope you're nicer than that. I hope you're nicer than that. That you're not what? Pulling my pellagra. Because if you're pulling my pellagra, that may cause the 4 what? 4 Ds. Which is dermatitis. So you stay in the front. I like these guys in the front. Okay, I like these guys in the middle sometimes. Okay, and I always like the guys in the back. Listen, pay attention. You don't know who's going to be watching that video. Do you want your school joked on and memed on and tic-tacked on? Huh? So come on, let's show what we can do. Huh? Tony the Tiger, you ain't never heard that? What can we do? Are we great? Then let's be great. We have no fear. Because fear is a what? Reaction. And we didn't choose that, did we? What did we choose? Courage, dedication. Come on, yes. All that stuff. That's what we chose, right? We're walking this stuff down, believe it or not. You're walking it down. Did you come in here knowing this information? No. But are you going to leave here knowing this information? Yes, so call it what you want. Roll it to the right, roll it to the left. I'm not pressed, I'm not this, I'm not that, but you're learning. Guess what? You're learning. So where did we leave off? What vitamin were we talking about? All right, so 3, 6, 9, 3, 6, 9, 12. You see that? 1, 2, 3, 6, 9, 12. For the B's. 3, 1, 2, 3, double, 6, add a 3, 9, add a 3, what? Not hard to learn, is it? Now, what's the saying Mr. Decker gave you to remember those B vitamins? Does anybody remember? Would it be mean of me to take my thigh and hit your ribs? Or should I be niacin and make you a pie in a pan? Would that be a better sign? Do you understand that? What's number one? Thiamine. Would it be mean of me to do what? Take my thigh. Would it be very mean of me? It would be very mean of me, wouldn't it? To take my thigh and do what? Put it in your rib. Instead, I shouldn't pull your leg pellagra. I should be niacin, right? And make you a what? But I'll need a what? Pan. And is that a better sign? That's how you can remember those B vitamins and those conditions that go with them. Do you understand that? Pretty simple, isn't it? Now, let's talk about pyridoxine. What vitamin is pyridoxine? B6. Now, you need 4 things, 4 basic things for red blood cell production. What are those 4 basic things? Protein, right? Isn't it called hemoglobin? What is the globin part? Is that a protein? That's a protein, isn't it? A globulin, a globin, isn't that a protein? It is a protein. The heme is a what? Iron. Ooh, protein, iron. And then we need 2 very important B vitamins, which are 6 and 12. And we need some folic acid. Do we understand that? So the B's, the iron, the protein, and the what? And if you have a deficiency in any one of those, that leads to what condition? Anemia, because anemia is caused by what? Or. It's an or. Lack of red blood cells or lack of hemoglobin. Do you understand that? Lack of red blood cells or lack of what? And the only other option is abnormal hemoglobin. Which type of anemia are we talking about here? Sickle cell. Sickle cell. Okay? All the other ones are caused by deficiency in those ingredients that I just named. Either you don't have enough protein, you don't have enough iron, you don't have enough B6, enough B12, enough folic acid, or you're making hemoglobins, but they're not normal. Do we understand that? So we did vitamin B6. What about vitamin B9? What do we call that? That's that folic acid, right? Huh? Folic acid. Now look up the relationship. Look up the relationship between folic acid and pyridoxine, the B vitamins. Look up the relationship between folic acid. What's up? Sure. Okay, and if you want, you can just take that stuff off that desk and just turn it around and sit there if you want. Look up the relationship between folic acid and the B vitamins. What happens sometimes where one could be depleted and the other one could be elevated, or the other one could be depleted and the other one could be elevated? What do you got on that? What does it say about that? Huh? If what happens? Come on, guys. I don't see a lot of people looking. What do you need to know about that? Could it mask? That's what I want to know. Is there a masking effect? What's that? Yeah, we understand that, but I'm talking about the relationship between folic acid and the B vitamins.
Well, folic acid is important. Excessive intake can mask the symptoms of B12 deficiency, potentially leading to serious health complications.
Can you say that again?
Well, folic acid is important. Excessive intake can mask the symptoms of B12 vitamin deficiency.
Do you understand that? Then you'll have pernicious anemia. Okay, if the folic acid gets too high, it starts canceling out the B12. Do we understand that? Okay, because look, no, pay attention. They push on you and push on you in maternity that what's important. Push the folic acid, right? Before you came in here, folic acid is nothing in excess is good. Do you understand that? Nothing in excess, even energy in excess. What does energy start doing when it gets too high? It produces too much heat, and then the heat starts doing what? Canceling out the energy. Do you understand that? Same thing here. Now, what's a well-known popular med that you give that depletes the folic acid? We need to know this. What well-known med, and I'll even give you a hint, this med affects the immune system. Starts with an M, M as in Mary. Methotrexate. Methotrexate. Who's got methotrexate pulled up? What does it say about methotrexate? What? Let me see it.
Anti-epileptic drugs.
All right, so it's given for what? Let me see this.
Oh, that's all the different. It's just all the different.
Oh, that's just what it interacts with. You're talking about? Yeah. I was going to say it's not an anti-epileptic med. Folic acid antagonist. What is methotrexate? So it could do what to your folic acid? Now look up leucovorin. 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 Look up leucovorin. Is that a folic acid analog?
It's an antidote to methotrexate.
Correct. What is the antidote to methotrexate overdose? Do we understand that? Okay, this guy was high on meth. His name was Lou. Next thing I know, he went and hid in a cave. Huh? Leucovorin is the antidote to what? Because methotrexate is a folic acid what? And leucovorin is a folic acid what? Agonist or analog. Do we understand that? So we talked about that. Did we talk about B12 yet? What is vitamin B12? Why is vitamin B12 so essential? No, we're getting to there. Let's talk about B12 first. Cyanocobalamin is important because it was one of those what? Right, one of those essentials for the formation of red blood cells. Okay, but how do we usually take B12 in? How do we usually get that? Through the GI tract. Okay, but what is needed in order to absorb it into the bloodstream? Where is the intrinsic factor produced? In the stomach. So if you have some type of gastrectomy or some type of resection of the stomach, what could be the issue? Not enough intrinsic factor. Okay, and not just that, the pH of the stomach can affect the production of the intrinsic factor as well. Do you understand that? Without the intrinsic factor, you can't do what? You can't absorb B12. And you're going to have what condition? What kind of anemia? Pernicious, delicious. Do you understand that? When you think of something through the GI tract, it needs to be what? Delicious. And if you can't get it through the GI tract, then it's going to be what? Pernicious. It's going to be suspicious for pernicious if it don't taste delicious. Do you understand that? Okay? You got to have that what in order to absorb that B12? Or, if the cells produce the intrinsic factor, what could it, besides having a surgery, what else did I teach you could affect the intrinsic factor amount? The pH of the stomach. What's the normal pH of the stomach? What is the only exception? What is the only exception? Come on, got to know this. If they're on antacids, it could be as high as what? 6. But if it's 7, you're about to send them where? Okay, because you're where? In the lung. Very good. Say it loud and proud, Mary. Okay. Very good so far. How many kcals are in protein and carb? 4. How many in fats? 9. What are the 2 types of carbs? What are the 2 types of proteins? We didn't ask about the fats, did we? What are the 2 types of fats? Saturated and unsaturated. What are the 2 types of fats? What are the 2 types of fats? Which one is the dangerous one? We got that? And all right, now let's start breaking it down. What did they say the recommended percentage intake of carbs should be? The recommended percent, the daily percentage of carbs should be how much? 55, 60%, right? Carbohydrates. How much carbs should you take in a day? Who uses that carb? So it's very essential, right? How much should we be taking in through the diet? Okay, what about the protein? Up to 30, that's about 15 to 20. I would say 15 to 20%, but yeah, I've seen it as high as that. And what about the fats, though? That's where your 30 comes in. That's where your 30. I'd say protein 15 to 20. Fats 30%. But what do you need to know? Out of that 30%, what?
How much is saturated?
No more than 10% saturated. What's the rule?
No more than 10% saturated.
No more than 10% what?
Saturated.
Everybody got that? We're getting there. You guys can read through this and it'll tell you, because you got to know the My Plate. Have you ever heard of My Plate? What is My Plate?
It's like an app.
To make sure you're covering all the groups, right? The food groups. You guys know what dietary intake values are and dietary recommended and allowance and all that. You know what those are? How much a person should consume in a day, right? Okay. We ever heard of the DASH diet? What is the DASH diet?
Like a low sodium diet, right?
Not necessarily just sodium.
Is that like the hard coding diet?
It stands for dietary allowances to stop hypertension. And the focus there is controlling the amount of fat that you eat, increasing the amount of fruits and vegetables and whole grains that you consume, and possibly lowering the sodium. Okay? It's up here. We got the DASH. We got the DASH. All right, look at this kind of stuff, though. See this kind of stuff. Okay, infants need how much fluid? What does it say? What's the rule of thumb? They should be producing how many wet diapers a day? 6. Okay. How much protein do they need? 2.2 grams a kilogram a day. And how long should they at least consume breast milk? But what's it advisable that they should do it to? 1 year. Correct. Okay. Do we know what the basal metabolic rate is? What is the basal metabolic rate? Basal metabolic rate. What does that mean? Doesn't that almost sound like the basic? The basal, doesn't that sound like the basic? So that's the amount of energy your body needs at rest. The minimum amount that it needs at rest is the basal metabolic rate. Do you understand that? Okay? If you're not doing any activity, if you're not doing anything, okay, that's how much you need to stay alive. Doesn't include activity though. As soon as you start becoming active, you need more what? Oxygen, correct. Therefore, more energy. All right, so here's all your breakdown here of the carbs that we already talked about. You can read through these. It'll tell you the difference between the simples and the complex. What are examples of that? There's what we talked about, the caloric need. There's the 50 to 60%. Okay? And this tells you what they do with the excessive carbs. They're stored as what? By what organ? The liver. The liver. We ain't never heard of glyconeogenesis. Have we ever heard of that? Glyconeogenesis. Then it goes into the protein, same thing. Just understand the three byproducts of protein metabolism. Let's talk about that. That's important. What is it talking about? Nitrogen. Nitrogen. We need nitrogen because that's the form of the protein after the liver breaks it down that repairs the tissue. We don't want too much nitrogen, but we got to have adequate nitrogen, so we have to keep the nitrogen level what? Balanced. Okay? Also, there's urea. What's the precursor to urea, though? Urea is a waste, right? What's the precursor? The precursor. When the liver breaks down the protein, what's the precursor to the urea? Ammonia. Ammonia. And the liver needs to take that ammonia and flip it into what? Urea. In order to eliminate it from the body. But when it can't do that, it stays as, which is a gas, and it goes where? Well, first it's going to go to that peritoneal cavity, right? Why? Why?
Gas goes to the dead empty space.
So what's happening is, because the liver can't deal with the proteins, you don't have enough proteins in your blood vessels to keep the fluid in the blood vessels. So the fluid's going to leave the blood vessels, and what cavity allows for the greatest amount of fluid to collect? Peritoneal cavity. And then there's also going to be ammonia in there because that's unprocessed protein metabolism. And then the combination of the fluid retention in the peritoneum and the ammonia making its way to the brain, and then you have what condition? What? This is ascites, but what would this be? Right. So the rule of thumb that you guys need to know about that is, if there's no suspected hepatic encephalopathy, what do we teach them about the protein? No, increase. As soon as we worry about the ammonia making it to the brain, then we do what with the protein? Decrease. Okay? All right, those are all your vitamins, the fat solubles, the water solubles. It goes through those again. Okay, then it goes into the minerals. Guys, do you know minerals are electrolytes are minerals, right? And you got two types of minerals. What are the two types of minerals? Macro and micro, right? Macro minerals, micro minerals. What's the difference?
There's one that you get naturally through food. Or no, some that your body produces, some that you have to.
There's one that your body needs in great amounts, which is macro, and that's basically your electrolytes. Magnesium, phosphorus, calcium, sodium, all them guys. And then you got micros, which you don't need that much of. They're only needed in small amounts. So that's the basic difference between macro and micro, how your body needs them. See, look. Calcium, phosphorus, potassium, sodium, chloride, magnesium, and sulfur. These are all essential, so these are macros. Your minors are these here. You don't need them as in great proportion as you do the other ones. Now, when we think of calcium, what do we think of? Medusa, I thought. Don't we think of Medusa? Anybody know who Medusa is? Who's Medusa? Huh? What happens when she looks at something? So it ossifies things. So could we say the same thing about calcium? It hardens things. It ossifies things. We need to know that about calcium, don't we? Because it's dangerous if it builds up in the body. What's it going to start doing? Ossifying and calcifying those bones to the point where you experience what? Bone pain. And eventually fractures. What is it going to do in the kidneys? Kidney stones. What is it going to do in the GI tract? Because it's hardening the stool. What's it going to do to the heart muscle? Make the muscle rigid. It could stop the heart. Do you understand that? Because calcium acts like who? Medusa. Now, as long as Medusa's balanced, we good. But if we get too much Medusa, then everything's going to what? Harden. Do you understand that? Another fact about calcium that you need to understand, it acts as a natural binder. Calcium is like a natural binder. So when you have elevations of other things in your body, you got to keep an eye on the calcium because the calcium's going to want to do what? And that inactivates the calcium. Do you understand that? When you have pancreatitis, for example, there's fat that gets undigested. And in order to get it out of your body, it's got to bind to something. Who do you think binds to it? Correct. When you're receiving a blood transfusion, you have to monitor the calcium levels because there's a preservative in that bag that calcium's going to want to do what with? Bind to it. When the phosphorus is elevated, the calcium wants to do what? Bind to it, which does what to the calcium level? Do you understand that about calcium? There's a lot of rules of thumb. When you get into the difference between Cushing's and Addison's, and you start that everything's up except the potassium, well, sometimes you have to include the calcium as well. Do you understand that? Everything's up except the potassium and the calcium, because if everything's up, the calcium's going to want to do what? Bind. Okay? And then what is the little acronym that we think of? Calcium is so important. Calcium, 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 calcium. What does it do? Calcium, calcium. Calcium, calcium. What does it do? Does it help with coagulation? Does calcium help clot blood? Oh my goodness. Yes, no, maybe, sometime, Saturday, Sunday. You guys, you should have rolled that right off. If you know anything about the clotting cascade, you'll know that there's two types of the clotting cascade, intrinsic and extrinsic. And both pathways require what element? Calcium. Without calcium, you will bleed out. Without calcium, what will happen? Can lack of calcium cause an arrhythmia? Can lack of calcium cause an arrhythmia? Can lack of calcium cause you to be lethargic? What can we use for this C? Will lack of calcium cause confusion? What can we use for the I? Lack of calcium. Come on. Will that affect the intestines? Would that affect the intestines? Okay. What about the U? What about, huh? Will it affect urination? What will it do for urination? Look it up. Hypocalcemia. How does that affect urination? Can't use it unless we can prove it. Huh? Can we use it if we can't prove it? Will it cause motor agitation? Huh? You ain't never heard of Chavostics and Trousseau's? Isn't that motor agitation? Is that motor agitation? When you see the spasming in the cheek? Or the spasms in the hands and the wrists? Is that motor agitation? Is this how you spell calcium? So can we use the word itself to remember the things that we need to remember? Always. We just have to be creative. Do we understand that? The C in calcium stands for what? The A in calcium stands for what? The L in calcium stands for what? The C could be confusion or chavostics too, right? Could we go chavostics too? We haven't covered the I yet. What are the effects on the intestines? Lack of calcium. What are the effects? And what are the effects on the kidney? The loop of Henle. The U looks like the loop of Henle, doesn't it? Come on, check bowel and bladder with calcium. Low calcium. Will it affect the GI and the urinary? What's that? Well, that'd be too much calcium, right? Well, look it up. You tell me. Indigestion? I like it. I like it. You need the calcium for the muscles to contract, right? There ain't no calcium and the muscles going to contract. Is there going to be any peristalsis? No. We need to figure out that urinary system, though. We know too much calcium causes you to urinate. Why? Body's trying to do what? Flush out the stones. Okay, but what about not enough calcium? Will that affect bladder contraction? Could that cause spasms in the bladder or what? Could it do anything? Look it up. It causes impaired kidney function. Does it cause impaired kidney function? So we remember that U in calcium for the loop of Henle, don't we? Will it affect that loop? Yes, it will. We got that? See how you can take something and make it easy. You can make it easy because if you got too much calcium, now what are we? So what are the 4 telltale signs of hypocalcemia? 5. Let's go 5. Let's go 5. Let's go 5. Javastic, Trozo, tetany, paresthesia. Huh? And bleeding. What? Say it again, Deckard, but don't say it by yourself. I won't. Come on, only 2 people in this class. 2 people in this class. 2 people in this class. Come on, let's try it again. Everybody got that? What is it? All right. See this? Who can read that? Can anybody read that? What does it say? What does that expression mean? Laugh now, cry later. Can anybody know that what that means? Laugh now, cry later. That means have fun now, but if you have too much fun and you don't take it serious, what are you going to be doing later? And here's the trade-off. Here's the trade-off. You guys probably got about 3 weeks until you're sitting for the boards. 3 weeks versus the rest of your life. 3 weeks versus the rest of your life. Because I don't know if anybody's explained it to you, but I would like to. There's a great chance of how you finish this will affect how you finish everything from here on out. Do you understand that? If you fail at this, then your brain has no choice but to accept what? Correct. So it'll be easier for you to expect that you're going to do what the next time you try. But that don't have to be. Do you understand that? It's your decision. Every day you wake up, you have a decision to make. Am I going to be who I always am, or am I going to improve and try to become something better? That's the choice that you get every single day when you wake up. I made a change yesterday. I bought a pill box because I wasn't taking my vitamins like I was supposed to. And I realized one of the reasons why I wasn't doing it is because you got to go through all the bottles and you got to get it, and then you got to put all the bottles back. And some mornings I'm just so lazy, I didn't want to do that. I'll be honest. So I figured, well, what if I made them all up for the week and all I had to do was pop the thing open, flip them over, took them this morning. See that? So I got my vitamins this morning, and I'll get them tomorrow because it's easier for me when everything is laid out and all I got to do is follow this sequence. See, that's not intelligence. That's comfort. Do you understand that? Sometimes you got to make it comfortable for yourself, but you got to get it done. There's got to be a plan. All right. Let's move into, we understand phosphorus, right? What's the importance of phosphorus? Does phosphorus keep calcium in check in the bones and teeth? Yes. So we do need it for the bones and teeth as well, phosphorus, right? Is phosphorus also involved in your cell membranes? They're made up of phospholipids, right? And have we ever heard of ATP? What does the P stand for? Is that energy? So we need phosphorus for energy production as well, right? So you can see what can happen if we have not enough phosphorus in the body. But at the same token, we don't want too much phosphorus, because what do we learn about that? When there's too much phosphorus, what do we lose? Calcium. So you got to maintain that balance. All right, let's go down to magnesium. What do we need to know about magnesium? Sorry, this is how they get down. What do we do about magnesium? What do we need to know about magnesium? Okay, what else? Smooth muscle relaxing. Magnesium is a what? Magnesium is a what? I would get to know magnesium. There's a couple of reasons why. Number one, it's used heavily in pregnancy to prevent what? Eclampsia. Also preterm labor, because it's a tocolytic, but more so it's used what? Everybody understand that? It relaxes the smooth muscle, so if the uterus is contracting too fast or too much, you can give the mag and it'll slow it down. That's a tocolytic. But it also suppresses the immune system. So it's not overexcitable, because that's what a seizure is, right? Can it affect the blood pressure? Yes, because it relaxes those blood vessels. And the blood vessels dilate when they're relaxed. What does that do to the blood pressure? But should we be using magnesium for blood pressure regulation? Not at all, because it's not predictable. Do you understand that? And I had that on my NCLEX. What is mag sulfate given for? And the choices were to control the blood pressure or prevent eclampsia. It can affect the blood pressure, but it shouldn't be given solely to do what? Control blood pressure. Because it has been known to cause blood pressure fluctuations. Meaning down, body goes, oh snap, and then raises it. Do you understand that? Okay? So it should only be used for what? What is the antidote to mag sulfate? And we learned earlier, wouldn't that make sense? Because calcium is a what? A natural binder. Very good. Okay, so mag sulfate. Now, another way they may get you is the effects of magnesium on the heart. The effects of magnesium on the heart. If you can't relax that heart, if you don't have the magnesium to relax that heart, what are you going to see on the EKG? Torsades. The twisting back and forth across the isoelectric line, because the muscle can't do what? Relax. And you need to know that. That's something you could see on the NCLEX. They may show you a picture of torsades. Or they may ask you, hypomagnesemia leads to what? Dysrhythmia. And you need to know what? Serious dysrhythmia. Torsades de pointes. Okay? And remember, when the mag is off, almost everything else is off as well. If you got issues, if you got a patient and you're trying to control their magnesium level, and you see all these other, you see, why is the potassium off? Why is the sodium off? Check the mag level. If you can't fix the mag level, usually you're not going to be able to fix the other levels. Do you understand that? Because of that relaxation, everything's going to be in an overexcited state. All right, the big, no, we ain't ready for the big one. The second big one, we'll go sodium. What do we need to know about the sodium? Huh? Say seizures? Did y'all say seizures? Well, you should. When it comes to sodium, what are we talking about? What are we talking about? What is that? Hypotension, if we don't have enough of that? We're going to have orthostatic hypotension. And if we have too much, then we're just going to have what? Okay? And sodium can affect what? If it's too high, what do we have? Dipsia. What does dipsia mean? Thirst, right? Does dipsia mean thirst? If our sodium is too high, aren't we going to have the sensation of thirst? What if the sodium is too low? If the sodium is too low, what's going to happen? Huh? Huh? Fluid retention, water intoxication, maybe. It depends. Depends how you're losing it. If you're losing the sodium alone, then yeah. But you could be losing it isotonic, right? Sodium and fluid at the same time. So it just depends. Okay? Sodium, very important. What do we think of? Sodium high or low? Seizures. Sodium high or low, what do we think of? Seizures. If the sodium's high or low, what precautions should we put the patient on? Seizures. Do you see why that's important? Mr. Decker ain't going to sit here and talk about something that you don't really need to know. If I talk about it, guess what? You really need to know it. Are you listening to me? Number one, when it comes to seizures, what do you think about? Seizures, seizures, seizures. Seizures, seizures, seizures. If the patient's sodium level is below 135 or above 145, what should you immediately put them on? Seizure precaution. Does everybody understand that? Without even playing around. And the rule, whoever said it a few minutes ago, correct. When the sodium's low, you said it, the fluid is usually what? When the sodium's high, the fluid is usually what? And you need to understand why. It goes back to the basics. What electrolyte is most abundant outside of the cell? So issues in your blood vessels are going to affect sodium the most. Are you listening to me? The osmolarity or osmolality in the blood vessels is dictated mostly by what electrolyte? So when the sodium levels go up, what's going to happen to the cells? They're going to shrink and shrivel because that hyperosmolar state is going to pull the water out of the cell. Are you listening to me? Not enough sodium is going to cause what issue? The water is going to leave the blood vessels and go into the cell and swell. Do we understand that? The reason why it's sodium is because sodium's the most abundant particle in these blood vessels. Meaning any problems usually in your cells, and we're thinking muscle cells predominantly, What electrolyte do you think about? Potassium and calcium. Because they're found mostly where? Potassium's found mostly in that cell. Do you understand that? So when you think potassium, you should be thinking what? Muscles. Because they're going to affect the operation of those cells that make up the muscles. Are you listening? Whereas sodium is just like the doorbell ringer. Sodium basically just, come on, Sal, can I touch? Come on, Sal. Come on, Sal. This is sodium and calcium. Come on, Sal. Come on, Sal. But if you don't have the potassium, you can sit there and excitate it all day long, but it can't do anything. Do you understand that? It needs the potassium. When the sodium and calcium come in and say, all right, come on, we got the potential, then the potassium needs to go and contract. Do you understand that? Okay? So that's why, and here, this should go, when people have a lot of pain, they use sodium and calcium channel blockers. So they can stop that, hey, you're in pain signal going to those cells. Do you understand that? If you ever see somebody that, why are they on a sodium channel blocker for pain? Or a calcium channel blocker for pain? Because it's blocking that excitation. Do you understand that? But it can also affect the other things. And that's why when you think hypertension, you also think of sodium, and you think of fluid retention, you think of sodium, only because, not because it's sodium, it's a positive ion, but so is potassium, but because of where it's located. Do you understand that? If sodium was the most abundant intracellular and potassium was the most abundant extracellular, then who would be the issue when it comes to seizures and blood pressure? Correct. You get it. Okay? So you need to think about that. When they're talking about sodium, where are you predominantly? Where are you in the blood vessels? When you're talking about sodium, where are you? When you're talking about potassium, where are you? Should be in the cell. Now, when the blood sugar elevates, potassium comes outside. Why? Why? Because it's trying to give room in the cell to get the sugar in there. Are you listening to me? Why would potassium come out of the cell? To try to allow the sugar to go back into the cell. Give up space. Also, when the pH drops and the hydrogen increases, potassium comes out of the cell. That's why acidosis, 9 times out of 10, what's the potassium going to be? That's why 9 times out of 10, hyperglycemia, what is the potassium going to be? Do you understand that? Learn all these things. These little shortcuts are going to help you when they're talking and describing things. You can understand what's going on in there. Do you understand that? What's going on in there? Because this is what's going on in there. Okay? It's all about polarity. We're trying to change that negative to a positive to perform an action. And the only way it can do that is to open its doors and let those instigators that say, come on. And then we got to have somebody like chloride to say, all right, that's enough. Leave Ronald alone or I'm going to punch your eye. You see that? Okay? Good old Ronald. Ronald's a good sport. Okay? All right. You got to have an idea of what we're talking about. Now, potassium. What did I say? Get that locked in your brain. That is the most important electrolyte going into NCLEX for you as a nurse. Do you understand that? What do we check before? 2 things that we, and don't say the potassium level, that's, come on, obvious. What are the 2 things we check before we ever administer potassium? Heart, so EKG, and creatinine. If you can't excrete the potassium, we can't give them potassium. Are you listening? Guys, you should have been on that. You should have been on that. There is not a nurse that should hit the floor and not understand the danger of potassium. I don't care how new you are. If you don't know how dangerous potassium is, you should not be working on a floor where there's potassium. Do you understand that? What are the two things you check before you administer potassium? And the obvious. And the potassium, the obvious, right? Is that the obvious part? But what are the non-obvious two sources that you need to check? E and D. Whenever a patient is on potassium and they have an issue, what are the first two things you need to go check? Everybody got that? Can we push potassium? How do we give potassium? On a pump, diluted, right? Diluted on a pump, right? Do we got to worry about potassium stripping them vessels, though? Is it a vesicant? Do we have to worry about that? Extravasation? Do you understand that? Should you be watching the IV site when you're running potassium? Should it be on a pump? Should it be diluted? What is the maximum amount of potassium you can give in an hour? 40 milliequivalents. 40 milliequivalents per liter. Do you understand that? 40 milliequivalents per liter in an hour. 40, 40, 40. Huh? How many can you give in an hour? Anything over what amount requires them being connected to a cardiac monitor? 10. Any more than 10, check the heart again. Any more than 10, check the heart again. Any more than 10, do we understand that? Potassium, potassium, potassium. You have to invert the bag to make sure that it's mixed well before you hang it. What do you got to do to the bag? Why? What do you got to keep an eye on? IV site. What else you need to be keeping an eye on? And what else you need to be keeping an eye on? In the urinary output, right? Are you listening to me? Potassium, potassium, potassium. Now I'm going to teach you a little trick, because they like to ask you about foods that are high in potassium, don't they? P-O-T, potatoes, orange juice, and tomatoes. How do you spell potassium? I'm too loud. Okay, how long do you think it'll be till they're done? No later than. Oh, and then will that class be empty after that? Okay, thank you. Be quiet. All right, let's take a break. Nobody wants us to learn. Let's take a break. Take a break. 10. Take 10. Okay. No. 10 minutes. What? You worked last night? You couldn't have taken all. You need that. You need them dollars, huh?
Yeah, I need that money.
That's terrible.
They had me off all last week because that was supposed to be finals week, and then we switched it.
Oh wow.
So now, and I tried to pick up, and of course they're like, "We don't need you."
What are we eating? Huh? What's that? What's that? Is that hot sauce on there though? Oh. Y'all don't get down. I gotta have my hot sauce. On eggs? You ever put hot sauce on eggs? Oh, it's good. It's good. Good on eggs. Potassium, potassium, potassium. Ah. Huh? Yeah, they are. No offense, I'm serious. Thank you.
Morning.
Hey, morning. All right, everybody signed in?
No.
Make sure you sign in if you want to get credit for the day. She's gonna make me give that to her.
My kids this morning were talking about, my 7-year-old told my 10-year-old, he's like, just pretend that you're sick so that she has to come pick us up early. I'm like, y'all better not do that. How are you gonna sit there and plot it? Just pretend you're sick. Right, I heard them in their room while they were getting ready for school. I'm like, don't do that. How are you gonna plan that? Just pretend you're sick and go to the clinic so she has to come get us early. That's what I have to say. You want us to sign in too?
Who? If you're here, yeah, put your name on the sheet. Just put your cohort beside it if you're not in.
I fixed it. That's why I kept my hands even after I married. But the first thing I got was that awesome. Not as if we did that.
Thank you.
They did? I told them to help there. They said it just. Well, took mine at work. Did you really? Yeah. I've taken all of them. But you're a supervisor, ain't you? See? Yeah, we're doing reconstruction for my office. What days you do? Friday and Saturday and Sunday. I don't want to.
All right, been 10 minutes? Yes, sir. All right. So let's talk about some things now. talked about water, right? The importance of water. Okay. So then you learn in fluid and electrolytes. We're not going to go through the whole fluid and electrolyte lecture, but there are some important things to understand. Let's go through the types of fluid. Isotonic, hypotonic, hypertonic. Hypertonic fluid is going to do what when you administer it? A hypertonic solution is going to do what? It is going to pull. A hypertonic solution is going to do what? Because the solution has a high osmolarity or high osmolality, meaning more particles than water. Do you guys understand that? So when you administer a hypertonic solution to a patient, where is it going to pull from? The cells. So it's great if you've got some edema, right? But if you pull too fast or too much, what could it do? See, that's what I'm talking about. And that's the type of questions they're going to ask you in that test. And you got to get to thinking, where are you administering the fluid? Start there. In the blood vessels. So if you're pulling, where are you pulling the fluid to? The blood vessels. So if you pull too much, too fast, what could you do to the circulatory system, which is the blood vessels? Correct. Yeah, because it's pulling it out of the cell, which is the tissue, not the blood vessel.
That's what edema.
No, that's angioedema. Edema is referring to the status of the tissue, not the blood vessel, unless you're talking about angioedema.
Mm-hmm.
We're not talking about angioedema. We're talking about edema, like cerebral edema. Guys, where are you administering the fluids? In the blood vessels. Where do you stick? You stick an IV into a cell or you stick it into a vein? Is the vein a blood vessel? Is that a part of the circulatory system? What makes up the circulatory system?
Veins, arteries.
Capillaries. And if you want to say heart, you can throw the heart in there, and you can throw the lungs in there too, right? And the liver and the kidneys if you really wanted to. Because that's where all the main destinations are. But when you're referring to fluids, where are you putting them? In the blood vessels. When you're referring to giving fluids, where are you putting the fluid? So the action is going to start where? In the blood vessel. And it's going to influence what? The cells. What you do in the blood vessel influences the what? So if you administer a hypertonic solution, what effect will that have on the cell? It'll pull fluid from the cell to the what? Blood vessel. And if you do it too fast, too much, it leads to what? Circulatory overload. Fluid volume overload. You need to understand this concept. We're not going anywhere until we understand this. Because I still don't think we fully understand this. Where are you putting the fluid? And what type of solution are we referring to? So if you administer a hypertonic, what's the consistency between particle, which we call solute, and water, which we call solvent? More solute than what? Solvent. Which makes it a hyper what solution? Hyperosmolar, hypertonic, hyperosmolarity. All of those things refer to the relationship between two things. Tonicity, osmolarity, osmolality refer to two things, a relationship. Are you listening to me? The relationship between the solute and the solvent, or the particle and the fluid. If it's hypertonic, it has more what? Particles. And it has less what? Water. So a natural process will occur to try to balance them back out, which is what? Osmosis. Osmosis. And the water is coming from where? The cells. And it's going to enter where? And if it's too much, too fast, what does that lead to? Circulatory overload, fluid volume excess. Any of those terms, it's the same thing. Do you understand that? Whenever you see volume, volemia, emia means blood, the volume blood. Where's the blood? In the blood vessels. Are you listening to me? So when hypervolemia, hypovolemia refers to what area? Blood vessels. Does everybody understand that? When you're talking dehydration, that's a direct reflection on the tissue. The tissue is how we determine hydration. What are we checking here? The tissue. We're not checking the blood vessel. Are you listening to me? So you start out when your body doesn't have enough water, the body's going to try to correct its own problem by pulling from where? The cells to the blood vessels. From the cells to the blood vessels. Because what's happening is the body will detect it in the blood vessels first when that hyperosmolar state occurs. That's going to set off all those processes in the body. Oh boy, we don't have enough fluid. All right, tell the kidneys, shut off. We ain't excreting nothing else. Do you understand that? That's why that antidiuretic hormone goes down to the kidney when the osmolarity is too high. We can't afford to lose anymore, can we? And then osmosis, where it's going to pull the water from the cell, but what happens to the poor little cells? They shrink and shrivel. Okay? To try to replace the circulatory volume, because the circulatory volume, or the volume in the blood vessels, is the most important. Because if the blood vessels ain't got enough, everybody's going to be affected. Do you understand that? Okay? I'd rather you lose the functional ability to move that arm than the functional ability to keep feeding the vital organs oxygen. Do you understand that? You need to know that. Hypertonic solution has more what than what? And if you give it, what is it doing? Pulling the fluid from the cells. So that could cause dehydration, couldn't it? That could cause dehydration too, right? Okay? But if you put in too much, too fast, it'll lead to what? Now, what are the signs and symptoms of circulatory overload or fluid volume excess? Okay, let's go to the top. Don't we always start at the top and work our way down? So level of consciousness would be the first thing, right? What is that going to cause with fluid volume overload? Confusion. A confused state. A confused state. Okay? And then what are we going to see possibly around the orbits of the eyes? Periorbital edema, possibly. What are we going to see in the jugular vein? What are we going to hear in the lungs and see in the lungs? Dyspnea, right? Are they going to be dyspneic, trying to deal with all that fluid? And then we're going to auscultate what? We're going to auscultate what? What are we going to auscultate in those lungs? I don't know what crackles are. I never heard of them, and I don't think they'll be on the NCLEX. But rhonchi and rails may be. Crackles is not going to be on the NCLEX. Are you listening to me? Rhonchi and rails. Let's look them up. Somebody look up rhonchi. Somebody look up rails. Somebody else look up wheeze. Somebody else look up a pleural friction rub. Somebody look up Strider. Let's get the names that you might see on the NCLEX. And under that wheeze, let's divide it between sibilant and sonorous. Let's understand upper airway obstruction. Which one of those does apply? Strider. Upper airway obstruction. Which one of those is applying? Affects the bronchioles. What are we talking about? Wheezy. Wheezy, baby. Affects the alveoli. What are we talking about? Bronchi. What are we talking about? Outside in the pulmonary bed, what are we talking about? Rails. Rails sounds like whales. Whales is going to be where all the fluid is, in the bed, right? Look them up. Let's look them up. What do we got? Who's got what? Who's got what? Who's got bronchi? Who looked up bronchi?
It says bronchi are low-pitched snoring or rumbling sounds caused by airflow through narrow or obstructed large airways. Rails, also known as crackles, are high-pitched, discontinuous popping and clicking sounds that occur when air moves in previously closed or collapsed airways, often in the smaller airways of the lungs.
Okay. What about sibilant wheeze and sonorous? What type of wheeze should you hear first? Usually heard first during which process of breathing? Inspiratory or expiratory? Which one? Expiratory. How do you know when it's getting worse? No, when you hear it on inspiration as well. And then the bad of the bad is when you don't hear it at all. Pay attention. When it comes to your asthmatic patients, what do you expect to hear in relation to breathing? An expiratory wheeze. How do you know when an asthmatic has worsening symptoms? Inspiratory and expiratory. And what's the worst of the worst? If the asthmatic patient has no what at all? No wheeze. We got that? You got that? Now, I want y'all to look up ARDS, Acute Respiratory Distress Syndrome. Acute Respiratory Distress Syndrome. Look up ARDS. What does ARDS stand for? And tell me what they say about adventitious sounds with ARDS. Tell me what they say about adventitious sounds with acute respiratory distress syndrome. Tell me if they say there won't be any with acute respiratory distress syndrome. Will there initially be adventitious sounds with acute respiratory distress syndrome? No. No, because the problem isn't originating in the lungs, it's outside of the lungs. Look it up. Who's got it?
Severe shortness of breath, rapid breathing, and other signs like fast heartbeat.
But ask about specifically, are adventitious breath sounds or absent adventitious breath sounds the hallmark of ARDS? Dyspnea is not an adventitious breath sound, though, right? Bronchi, rales, wheezing are adventitious breath sounds. Right. That's not an adventitious sound. But that's not what we're talking about. Dyspnea is a sign of a lot of things. What you need to know is you may not hear any adventitious breath sounds, and they could be in ARDS, acute respiratory distress syndrome. Do you understand that? So what is the hallmark of ARDS? What is the hallmark of ARDS? Okay, so at what level? It's an FiO2 of 60% or greater with a PaO2 less than 60, 60-60, or a PaCO2 greater than 45. What is the hallmark of ARDS? All right, hold on a minute. Am I dyspneic? Do I have ARDS? How would you know? You wouldn't. I could just be anxious, right? Could I be having a panic attack? So could you associate dyspnea with ARDS? No. You could not. But what could you associate with ARDS? A PaCO2 greater than what? 45. With an FiO2 greater than? With a PaO2 less than? That means you came in here dyspneic, which could be anything, and I put oxygen on you, and I'm running greater than 60%, but I can't pick your PaO2 above 60. Do you understand that? That's how I'm going to know that you have ARDS. It's not going to be just because you showed up and you were dyspneic. Do you understand that? Dyspnea does indicate respiratory dysfunction. But the questions that they're going to be asking you on the NCLEX are going to be referring to the fact that you may not hear any adventitious breath sounds and that you need to do an ABG because you need to know the PaCO2 level, the PaO2 level. Do you understand that? All right, so what are the mechanisms that the body has to maintain blood volume? Say the blood volume drops too low. What mechanisms does the body have to maintain that or pick it up? The RAS, that's one. RAS, correct. So ultimately, what is the final reaction of RAS? Physically, what does it do? What's the final product of that RAS process? Physical property. What is the physical property that is produced by RAS? When the renin is released, it combines with the angiotensinogen, becomes angiotensin 1, goes to the lungs and combines with angiotensin converting enzyme, it becomes angiotensin 2. Then what is it going to do? It goes to the blood vessels and does what to the blood vessels? Vasoconstriction. So not only do we need to remember that one of the mechanisms that we have is called RAS, we need to understand what the outcome of RAS is going to be, which is what? Vasoconstriction. So what else do we have besides vasoconstriction? We're trying to increase the blood pressure here, right? Do we have aldosterone? Aldosterone. What is aldosterone going to do? We don't know.
Won't that increase the fluid by
Sodium. Sodium. Aldosterone focuses on what?
sodium?
So aldosterone is going to go down to the kidneys and say reabsorb all the what? And as a result, the kidneys are just going to dump what? Potassium. Okay? So we're going to get sodium reabsorption, vasoconstriction, sodium reabsorption, and through a natural process called osmosis, we'll get a little water with the aldosterone too. But what else in the body will ensure that we get all the water we can? ADH, antidiuretic hormone. So you got to remember those three big mechanisms. First mechanism ends in what? Vasoconstriction. Second mechanism ends in what? Sodium reabsorption. Third mechanism ends in what? Water reabsorption. So the question is asked again, what three main mechanisms does the body have to help maintain blood volume or blood pressure? Vasoconstriction, sodium reabsorption. Bingo. Now, what mechanisms does the body have when there's too much fluid? What mechanisms does the body have when there's too much fluid? It has peptides. It has peptides in the chamber of the heart, doesn't it? There's the atrial natriuretic peptide and the brain natriuretic peptide. When those chambers are stretched too much, these peptides are released and they go down to the kidney and tell the kidney what? Dump the sodium and dump the water. Dump the sodium and dump the water, which is going to decrease the what? The blood pressure, the blood volume. Which one of those is the one we use when a patient may have heart failure? See, you get in there on that NCLEX and they go, the nurse is taking care of a patient with a BNP greater than 500. What do you know? They're in what? Heart failure. They're in heart failure. Do you understand that? What is the diagnostic lab that we look at to determine if they're in heart failure? And we got to know anything greater than 100 is too much, isn't it? That's too many peptides. Why would there be that many peptides? Because there's too much fluid the heart can't handle. And the heart is starting to what? Fail. So the BNP is a good indicator of what? Anything over what?
100.
Everybody got that? What is the parathyroid? First, what's the thyroid? Let's go there. What's the thyroid? What's the thyroid? What's the thyroid? What does it do? Metabolism. What is metabolism? Huh? Energy production. That is what we're trying to get accomplished with metabolism. To do what? What are the two types of metabolism? Anabolism and catabolism. So we're either doing what or what? Breaking down and releasing, or building up and storing? Building up and storing is anabolism, right? Catabolism is breaking down and releasing. Okay? Right here, what did my body do here? Whole bunch of what? Anabolism. Okay? Whole bunch of anabolism here, right? The rest of my body, they probably did what? Catabolism. But over here, we done built up too much and stored. Okay? What is the byproduct of energy production? What is the byproduct of energy production? Heat. Heat production. The byproduct of energy production is what? Heat. The byproduct of energy production is what? Heat. Correct. What else does the thyroid do besides regulate metabolism? What else does the thyroid do besides regulate metabolism? What's that? Calcium. Calcium. What does the thyroid release? Calcitonin. And what does calcitonin do to the serum calcium level? It decreases it. See, why is this important? Why should we know this already? Because if you take care of a patient with a thyroid disorder and you don't know to monitor the calcium because that thyroid disorder is going to have effect on the serum calcium, then guess what? You shouldn't be assigned to that patient. Don't take care of any thyroid patients if you don't want to learn that. That's a basic entry-level registered nurse should understand that not only does the thyroid lower the calcium, but the parathyroid increases the calcium. So if you have hyperthyroid, what could happen to your calcium level? If you have hypothyroid, what could happen to your calcium level? Because you're not getting the calcitonin support. Do you understand that? Not to mention the T3 and T4 from hyper or hypo, what's going to happen with that? But you also have to respect the calcium. Does everybody understand that? You got to respect the calcium with the thyroid. You got to respect the what? The front part of the thyroid does what? Which is called the thyroid. Does what to the calcium? It decreases the serum levels of calcium, right? And what are the 3 ways that it does it? What are the 3 ways that it lowers the serum calcium levels? Bone, causes the bone to reabsorb it, right? Intestines, it prevents the reabsorption in the intestines when you eat. And then excretion in the kidneys. It enhances the excretion of the calcium. That's how the calcitonin works. What is the gland on the back of the thyroid called? What does that do? The serum calcium levels. Now, I want everybody in here to look up ionized versus non-ionized calcium. In school, you've been learning that you check the calcium, which is normally 8.5 to 11, right? But as a registered nurse, you need to be aware that that's not the best indicator of calcium status. The best indicator of calcium status is going to be the difference between your ionized and non-ionized calcium, because that's the difference between the part that's active and the part that's inactive. Do you understand that? So you could have a total calcium level anywhere between 8.5 to 11. Okay? But if you don't have ionized calcium to non-ionized calcium ratio balanced, you're going to have a problem with the calcium. Do you understand that? Everybody looking that up. Ionized versus non-ionized. What does it say? What you got?
Ionized is the amount of freely circulating calcium in the blood. Non-ionized is bound to.
When it's bound, it's in an inactive state. It does your body no good. Do you understand that? So which of the 2 is the most important? What is the normal ionized level of calcium? Do you see why this is important? Listen to me. Pay attention. The LPN comes to you. Hey, I'm taking care of this patient. I did the calcium labs. The calcium is at 9. What should be your next question? Bam. Do we understand that? And that's what the doctor's going to want to know. Do you understand this, guys? Should you know? Why should you know? You're not the doctor, right? So why do I need to know that? Because you want to make sure them orders are written, that we're getting the proper labs, that we're looking at the proper things, that the doctor's aware of the important things. Do we understand that? Which one is the most important calcium? Non-ionized is what? Inactive. Inactive. Guys, do you understand medications? And you should, because you're giving them. When you give a patient a med, do you think they receive all that med at the tissue? No. A portion of it gets inactivated. It binds to a protein. Another portion of it dissolves in the plasma that's carried around. and another portion of it is already in the tissue. But when the amount in the tissue gets too low, now that natural diffusion process can take place between what's diffused in the blood into the tissue. Then the bound part can now diffuse unbound to make up for what has left in the dissolved part. Do you understand that? And that's why it makes sense to give a loading dose, a bigger amount at first, because you need to understand that out of that dose, most of it is going to do what? Be bound to the proteins that are carrying it. Do you understand that? And as long as it's bound to the protein, it's inactive. That's why we learn about half-lives. That's why that stuff is so important. Because if all of a sudden, all of that became unbound from that protein, that's when it's going to be toxic. Do you understand that? So you have to have that smooth delivery. I give you a med, part of it binds, the other is in the plasma, it diffuses into the tissue, and we've got equal portions between all three. If we have unequal portions between any of the three, it's going to affect the other two. Do you understand that? That's why you can't afford to miss a dose. You miss a dose, this gets too low, it pulls from the free, it pulls from the bound, now you have nothing. Do you understand that? So you got to understand these things. That's why these things are so important. Somebody look up a thyroidectomy. Thyroidectomy. Let's look it up. In nursing intervention, thyroidectomy. Nursing intervention, thyroidectomy. NCLEX. Nursing intervention, thyroidectomy. You guys realize the thyroid can affect the brain? Can the thyroid affect the brain? So it can cause depression if you don't have enough? Can it cause psychosis? If you have too much thyroid, could it cause psychosis? Yes. Because it affects the brain, because it affects metabolism. The brain needs that metabolism, right? So it can use the nutrients. But if you don't have enough thyroid or too much thyroid, it's going to affect the brain, right? So should you always do a thyroid test before you diagnose somebody with a mental health condition? You need to know that. You have to rule out what before you can diagnose somebody with a mental health disorder? Big time. Big time. Depression. Depression. That could be caused by inadequate thyroid, right? That's one of the signs of hypothyroid, right? Lethargy, depression. Everything goes down when you don't have enough thyroid, and everything goes up when you have too much thyroid, right? Think about it. What do we got for that thyroidectomy? If you remove that thyroid, it could bottom out your what? So does it say you should have calcium gluconate on standby? Calcium gluconate on standby. Is there going to be an incision there? Yes. What are the teachings for the incision? Should you hyperextend the neck? No. What does it teach you about that?
Monitor for edema and stridor.
Stridor. We need to be on the lookout for stridor because of that edema. What would be a sign of bleeding? Excessive swallowing? What else? Tachycardia? Does tachycardia signify a possible bleed? And then eventually what? Hypotension. And then are you going to get the Travostics, the Trazos, all that stuff? The tetany, the paresthesias? Could it result in seizures? What else? What else does it say? Support the head and neck. Does it talk about pillow?
Yes, with pillows or sandbags to prevent strain to avoid disruption of the suture line.
Everybody heard that? Need a pillow or a sandbag to prevent stress on the what? The suture line. Everybody got that? Those are highly tested things. That's what they want to know. Can you go and take care of a patient that had a thyroidectomy? Are you an entry-level nurse that could walk onto the floor and understand If they had a thyroidectomy, what you got to be aware of. The NCLEX is not about testing your knowledge. It's about testing whether you're paying attention or not. That's what it's about. They don't want any unsafe nurses out there. That the orders are going to be coming by them and the things are going to be coming by them, and they too busy on their cell phone. Text, ooh, I'll be there at the work. No, that's not a registered nurse. Registered nurse has to be responsible, ready to go at all times. Do you understand that? No questions asked. Call light, boom, I'm there. Not, hey, could you answer that call? No, you answer that call light. Who's the most prepared to answer that call light on that floor? So if it comes down to you and the LPN and the CNA and the light goes off and none of y'all are doing nothing, who needs to go answer the light? Huh? Explain to me, what is CNA work? What is CNA work? What is the CNA responsibility? Assisting. They have none. They have no designation. Do you understand that? They have no designation. They're to assist you. You're delegating basically when they're wiping. You're delegating when they're entering urinals, when they're replacing gowns. That's not their assignment. They're a certified nursing. I'm just assisting. I'm just supporting. It's not my accountability. Whose accountability is it? Let's talk about blood pressure. We're going to talk about all kinds of things. Let's talk about blood pressure. What's the ideal blood pressure?
120 over.
120 and less than 80. Okay? Under 120, under 80. But above 90 and 60. 90 to 120 and 60 to 80. Do we understand that? What happens if I'm 120 to 129 but still under 80? Okay, elevated, right? And then what if I'm 130 to 139 or 80 to 89?
That's the
Stage 1. Okay? Now, don't get caught up in the stages because there's two scales. There's actually two scales. The American Heart Association is the one that I teach, and that's the stage 1, which is 130 to 139 or 80 to 89. Anything over 140 and or 90 would be stage 2. But there's also the National Institute of Health or something that has their own, and they consider stage 1 as 140 over whatever. It's different. All I expect you to remember out of that is, when do we start medications? When do we start medication?
stage 1.
See, don't want you to remember it by the stage. I want you to remember by the number.
130.
140 or better, and or 90 or better. So you could have a systolic of 130, but your diastolic is 100. That's still too high. Diastolic's too high. Do we understand that? So that's when we start medication. Before that, it's what?
Lifestyle, dietary changes.
What the heck going on out there? She probably passed the test or something. Yeah, calm down. I wish y'all were that enthusiastic up in here. Come on, I need to bring her in here. Huh? Do we know the difference between a vegan, lacto-vegan, and lacto-vegetarians? Do we know all that? You got to know that. Okay? If they're a straight-up vegan, what? Okay, but if they're a lacto-vegan, then what does that mean? No, lacto is not eggs. Ova is eggs, right? Okay. All right. Do we know about our therapeutic diets? There's that DASH diet that we were talking about. Look what it says. You want to eat foods rich in nutrients, including potassium, calcium, and magnesium. Okay. The standard DASH reduces that sodium to what? But there's a more restrictive one that reduces it to 15. Do we understand that? Okay? Then you got your other type of diets. You guys can read through these. There's nothing I have to explain to you except this. Before you ever advance a diet, you need to be checking what? How about bowel sounds? Do we need to check bowel sounds?
Yes.
If they're taking anything PO, you should have already assessed their what? Gag reflex. Okay? So the priority assessment is to check what before you advance the diet? We understand what acid ash diets are for, right? Prevent kidney stones. You need to know that. Acid ash diets prevent what? And you see what you got to restrict. No carbonated beverages, dried fruit, banana, fig, chocolate nut, olive, or pickle. You guys know what a mechanical soft diet is? Now look at these low protein diets. What does it say? Look up there. When do we start advising low protein? If they have a burn, if they have anemia, if they have malabsorption syndrome, ulcerative colitis. Okay? For these, we're going to have high quality proteins or protein supplements. Okay? Now, for low protein diet is for what? Like what?
Arthritis, anemia, kidney failure.
So if the kidneys aren't able to keep the protein from leaking out, then we're going to lower it because it's just going to cause kidney damage. Do you understand that? Okay? So we want to restrict the protein. And then we know also with the liver. With the liver, what do we know about the liver?
High protein, unless you have signs of encephalitis.
Encephalopathy, then.
Encephalopathy, and then you go to low protein.
All right, very good. All right, what's a purine diet? Are we just reading off the screen, or do we know what the purine diet is for? All right, so this is what you need to understand, though, for real. Pay attention. Purine enhances the uric acid level. You have uric acid in your body at all times. Do you understand? So if they have too much uric acid, that uric acid can crystallize and embed itself in the joints. And one of the joints that it usually goes to is the big toe. Okay, so then they'd have to be on this low purine diet because these organ meats facilitate more uric acid. Do we understand that? Okay, so you need to know what a purine diet is. It just doesn't just include organ meats. What else does it include? Gravy, fowl, anchovy, beer, and wine. Okay, and then it's got more down here. You see all these? Mackerel, sardines, scallops, etc. Okay. Also, look what it says here. Diets high in purine and high in what? Can also cause gout. Okay, so if that's the case, then you're going to have to lower the protein as well. You guys know what gluten diets are? Now look at this renal diet. Look, this is important to remember. They're going to want to know that you understand this. If the kidneys are tanking, we already learned one just a second ago, which means what? Protein, but also sodium, phosphorus, calcium, and potassium. Why? Because they're excreted by the kidney. So we don't want them building up, do we? Okay? So then you look at the foods that are low in potassium and the foods that are high in potassium. But remember the trick that I taught you. You can use the P, the O, the T, and the A, right? And the S. You can use potato, orange juice, tomato, avocado, and strawberry, and spinach. So you can use both S's. And the M for the mushroom. You see that? So the thing has almost all of them that you can use. Potassium starts with a P. What does that stand for? O for potassium. What does that stand for? T. A. S. S. Okay, M. We understand that. Okay? Very good. All right, so that's some of those diets. All right, let's go into this tube feeding. This is stuff here that we need to understand, right? Okay, tube feedings. What is the most solutions of tube feedings going to do? What are they going to do? Somebody's being fed by a tube. What's going to happen here? What are the consequences of being fed by a tube? Hmm? I like the diarrhea. You need to consider. I'm just now getting messages. Rebecca told me she's gonna be late. Just now got the message.
Aspiration.
Huh?
Aspiration.
What about blood sugar, guys? What about dehydration? Do we got to worry about dehydration? Most solutions are hyperosmolar, hypertonic. Do you understand that? And we got to worry about the blood sugar going up as well, right? And then somebody said diarrhea as well, right? So look at these big things that we've got to worry about here with TPN. We got to also worry about what's called refeeding syndrome. Look it up right now. Refeeding syndrome. Refeeding syndrome. What does it say about refeeding syndrome? It's a fluid and electrolyte imbalance, right? Caused by what? Rapid shifting. So, what are the signs and symptoms of refeeding syndrome? What? What did you say? Hypotension? Hypotension?
That's what it says. What are the
Hypotension. What else?
muscle spasms?
Muscle spasms. What else? Pulmonary edema. Pulmonary edema. Hypotension. What else?
Kidney dysfunction.
Kidney dysfunction. So out of all that, which two are the most important that you heard? And hypotension. Hypotension and pulmonary edema. Hypotension and what? Now, think about this. What does the body do to compensate when it's hypotensive? Bam. Where's the first place that it ships its blood? No, to the lungs. Didn't it just say pulmonary edema? Do you want this patient to be tachycardic? With hypotension? With pulmonary edema? Okay, so we need to keep an eye on that when we're running feedings, right? What do you do if this happens? Slow down the feeding. Slow down the feeding. And should you check for this every time or just one time? Every time. Okay. What type of vessel does the TPN need to be ran through? What kind of vein? Huh? A large vein, such as the central veins, right? Do we want them in tiny veins? Does it need to be through a large vein? Can you run anything else through that TPN port? What position do you put them on if they're in TPN? At least what? At least 30. Okay? And then look what it says, the volume. The residual volume needs to be under what? Because you got to check that before you put anything in there, right? Under 100 mLs. Anything over 100 mLs, what are you going to do? Huh? What? What'd you say? Contact the provider. Are we going to hold the feeding? Are we going to assess bowel sounds? How do you assess tube placement? What is the only definitive way to assess X-ray? But you have to check two ways, don't you? Don't you have to check two ways? Or you can only check one way? Two ways. So you're going to do that X-ray, then you're going to do the what? See what it says? At least how high? It says this is telling you if you run into feedings, you want them in high foulers for at least 30 minutes. You see that? For continuous feeds, you can put them in the semi-fouler. Okay? Look what it says here. This is very important. How do you prevent bacterial growth? What does it say? Change the bag and tubing every what? And the tube feeding formula every. Did you write that down? That could be a test question. The 24 hours is the tubing. That's the easy one. But remembering that you got to replace that formula every half shift or whole shift. Okay? And then you're going to check. It says here, the rate should be no more than what? 300 mLs an hour. It says to prevent fluid and electrolyte imbalances such as that refeeding syndrome, administer the tube feeding at a rate of no more than what? 300 mLs an hour. And you're going to assess gastric residual at least how often? If it's continuous, every 4 hours, and intermittent before each. We got that? Hola? It says here, administer feeding as prescribed rate or by way of gravity flow with the use of a what type of syringe? 50 to 60 mLs. Okay? Administer the feeding by way of gravity. If you're giving them an intermittent bolus, you need to use what type of syringe? 50 to 60 mLs. Okay? And then you're going to flush with what? When? Okay? All right, look what it says here. If aspiration occurs, and what are signs of aspiration? What are signs of aspiration? Coughing? Somebody said coughing. Very good. What else? I can't get my way. All right. Okay. Monitor the temperature for indications of aspiration pneumonia and place them or prepare them for chest radiography. We got that? All right, let's talk about some of these questions here. It says, a clear liquid diet is prescribed for a client who has undergone surgery. Which items should the nurse offer to the client? Select all that apply. So we know gelatin is clear, right? And we know that ginger ale is clear. What would sherbet be considered? What would sherbet, tomato juice, and strained soups be? Very good. Number 2, a client with hyperlipidemia has been prescribed a high fiber diet. Which items should the nurse instruct the client to include in the diet? Did you guys know that pasta is high fiber? And what about white rice? Okay. All right, these questions are a little bit too easy. Let me see this one. Yeah, because it's just asking about fluid. All right, look. Oh, here's a good one. Look at this. You see this term here, azotemia? Azotemia, azotemia. Okay, somebody look up azotemia. Azotemia, waste in the blood. Look it up. Azotemia. See, you could see stuff like that on the NCLEX. Azotemia. What is that? Anybody got it?
Elevation and buildup of nitrogenous products, increasing the blood and other secondary waste products from the body.
Why? Because of a reduced glomerular filtration rate. So the kidneys go shot, and then what starts building up in the pot? Huh? Protein, right? With nitrogen, in the form of nitrogen. Nitrogen is a byproduct of protein metabolism, right? So the body can't excrete it. It starts building up in the blood, and what do we call that? Azotemia. What? What is it called?
Azotemia.
And what does that mean, basically? So basically, what's going bad here? So you see azotemia, they got what kind of disease here? and then it goes right into glomerulonephritis. And that is the responsible. Who's responsible for the filtration? The glomerulus. Pay attention. What structure in the kidney is responsible for the filtration? So if they got glomerulonephritis, that glomerulus is inflamed. Do you understand that? And that's going to affect its ability to filtrate the blood, right? Which is going to lead to the buildup of waste, and they call it what? Correct. Okay? It says glomerulonephritis, inflammation of the filters in your kidney, the glomeruli. It says the glomeruli remove excessive fluid, electrolyte, and waste from your bloodstream and pass them into the urine. Okay? It can be acute or it can be chronic. If it occurs on its own, it's primary. If another disease causes it, it's called secondary. Okay? Signs and symptoms. Okay? It says pink or cola colored. You remember that? They passed the final. Today's finals, guys, so they must have passed. Okay? If you got pink or coca color urine, those are my guys too, my LPNs. If you got pink or coca colored urine, you got to remember that one. Huh? What's the hallmark of glomerulonephritis? Coca-Cola, right? Coca-Cola? Coca-Cola. You got the gola. Huh? If you pee in Coca-Cola, you got the what? That's right. You got the gola because it made you swole up. Huh? Also makes the urine foamy. So not only is it going to be pink or Coca-Cola colored, it's also going to be what? Foamy. Homie. Your urine is foamy. Okay? This will lead to what? Right, because you're not able to remove the fluid, are you? Fluid retention with swelling evident in your face, hands, feet, and abdomen. What did we talk about this morning? What do we call that? All right. And fatigue from anemia, because guess what? You ain't got that erythropoietin being released, do you? So you're going to have red blood cells? See, this falls back. Where does it fall back? It falls back. It falls back, Jack. Where does it fall back? To knowing what the kidneys do. To knowing what the kidneys do. What do the kidneys do? One.
Filter your blood.
Beautiful. Beautiful. Two.
Excrete urine.
Okay, so they remove waste from the blood. That's kind of what she said, right?
Okay. Yeah.
Okay? See, one day, pretty soon, a doctor is going to come right above you. Hey, who has my patient? You ain't going to never seen them before in your life. And they're going to ask you a question. What you going to do? You going to answer them or you going to slide down and look like you're afraid? Just give them the information. You know the information. Give me one. Kidney. And see, we can't go into the NCLEX just knowing that the kidneys. Right. Regulates fluid and electrolyte. Very good. What else? Huh? Right. So it helps with fluid and electrolyte. That's the fluid and electrolyte aspect. Blood pressure's up, it's going to get rid of what? Fluid and electrolyte. Blood pressure down is going to keep what? Fluid and electrolyte. Everybody got that. Does it regulate pH? You got to know this stuff. If my kidneys are shot, please know I'm in metabolic acidosis. Please know that. If you're my RN and you're standing over Decker when he gets old, please know that if my kidneys are shot, my potassium and my pH are going to go in the opposite directions. Do you understand that? Or you're going to kill me. And if I have a respiratory condition already, guess what? Game over. Because how am I going to compensate? If my kidneys are shot, my lungs are shot, and then my kidneys get shot, How am I going to release hydrogen to get rid of the acids? How am I going to manufacture sodium bicarb to cancel out the acids? How am I going to excrete potassium? I'm not. So I'm automatically going to go into what? Metabolic acidosis. If my kidneys are not functioning, what metabolic issue is that going to cause? Do you guys understand that? If your kidneys go, that's your acid. If the kidneys go, that's your acid. Do you understand that? And there's no use sitting on the pot because the pot isn't going to work. The potassium's going to be high and the pH is going to be low if the kidneys don't show. Do you understand that? Guys, some of it's, some of it's cool and some of it's, yeah, and all that. But then some of it's not. Seriously, some of it's not. Some of it's, come on, man. This is one of those come on, man things. You, the registered nurse, you're responsible for supervising and overseeing the PNs and the CNAs. Not to mention your own patients. And you want to know what those kidneys do. Do you understand that? Because there's going to be several nursing interventions that you're going to have to employ when they have messed up kidneys. And if you don't know what the defects are in the kidney, you won't know the interventions. If I'm not able to eliminate the waste from my blood, do I possibly need dialysis? Do I need to avoid people with infections?
Yes.
Are you going to have to keep an eye on the osmolarity of that blood?
Yes.
Could that lead to frequent and severe dehydration?
Yes.
If I'm not able to regulate the electrolytes, could that cause cardiac dysrhythmias? Is that going to affect mental status? If I can't synthesize sodium bicarb, can I neutralize acids?
No.
If I can't release erythropoietin, am I going to have enough circulating red blood cells? If I can't synthesize vitamin D, am I going to have strong bones and teeth?
No.
If I can't eliminate any fluid, is that going to affect my blood pressure? We got to know what the kidneys do. We got to know what every organ does before we go to NCLEX. Because if they ask you about a disease process, knowing what the organ does will tell you what the disease will affect. Do you understand that? Glomerular nephritis, pyelonephritis, it don't matter. Polycystic kidney disease, they're all going to have similar things. Hypertension is one. Do we understand that? Weight gain is two. Elevated sodium, acidosis. They're all going to have those things in common. Are you listening to me? All right, so we cleared that. There's questions here. We ain't going to go into these because these are too easy. Y'all can look over them questions yourself and read the rationale, but they're easy. I made one for Friday, which I think you'll find a little more exciting.
Based off of these questions?
Based off of these manuals. I didn't make y'all's final.
Oh, we know.
I wish I was allowed to make the final.
They couldn't make it.
Huh?
They couldn't make it.
No, Miss Kayla made it.
Oh, really?
Yeah, she's pretty fair. All right, What time is it?
Time to go home.
All right, let's take a break. Okay. 5. What time is it? 10:33. 5 minutes.
I didn't do the share plug. So you're hogging the plug.
One of them is for that video setup. That's not me. Why? What do you need to do? Charge your laptop? We'll charge it and then unplug it. All right. We'll just have to share. Because mine can run a while. I got a full battery, so charge yours up and then we'll just keep swapping out.
It's gonna be a long day.
I'm prepared. I like long days.
I've had 2 long days. I worked 16 hours Saturday and 16 hours Sunday.
You're welcome. Huh?
Break.
Yeah, we're taking a break. This is our second break. They'll be able to edit that part, right?
Yeah. Let me see that real quick now. I'm gonna charge this while you're sitting on the time. Appreciate it. Testing. Okay. I've looked. That's it. If you see it, you see it. Don't look for it. I'll sweep the room when everybody's gone. You will tell him to put his mic back on when he comes back now. Right there.
How are we holding up? How are we holding up? All right, I want to fit in some stuff in here. because it goes into mobility and immobility here. That's what we're learning about next. Okay, mobility versus immobility. So freedom of movement versus restriction of movement. Okay, I'll give them another couple minutes. They done taking that final over there? They are? See how happy them guys are out there? Them guys are ecstatic, man. Feels good when you realize that you can accomplish something. What's the saying? What's the saying?
Which one? You don't use it, you lose it.
In order to get something that you never had, what do you have to do?
Do something you never did?
Yeah. Do you believe in that? And then also the saying that goes, if it's worth anything, it's going to be what? Hard challenge. If it's worth anything, it's going to be a challenge. If it's not worth anything, then it's not going to be a challenge. Or you won't allow it to be a challenge. You gotta remember that. You gotta think about those things. When I was a young man, I didn't believe too much into motivational things and all that kind of crap. And I know why now, because I didn't need it. I'm motivated. I don't have an off button. You understand that? When I want something, I get it. Not because I'm special, not because I'm this, not because I'm that, except I'm determined. And I'm not going to give up. You understand that? Failure to me is a friend. To me, failure is a friend. Why? Because it tells me what I need in order to be where I'm supposed to be. A lot of us don't look at failure that way. We look at failure as the enemy, right? Failure is your friend. Because have you ever had that saying, two things are too good to be true? Or this is too good? Because there's no what in there. There's no failure. You need that failure. That failure keeps you honest. You understand that? It keeps you honest. Should you want to fail? No. But should you be okay with failing if you gave everything that you possibly had? Yes. You should respect it. Okay? You should respect it. Now, you guys happen to have a bonus here where you happen to have a school that cares dearly about you. That's why we're doing this. This wasn't a part of the program. This is something they added into the program to help you. If you were to try to obtain something like this at another school outside of that school, $2,000 to $5,000. Do you understand that? Per person. But your school is giving it to you for free. And the reason why the school is giving it to you for free is because they want you to pass the NCLEX, which helps the school, right? You will always be a part of this school because this is where you received your degree. So in a sense, you are part of the school forever. Do you understand that? Every time somebody asks you, where did you go to nursing school? Taylor College. You're not going to be able to say you went somewhere else because you went here. So you are a part of this forever. Do you understand that? This is like your fraternity. As a nursing student, you should want this school to do well beyond you. Does everybody understand that? Why am I talking about all this? The reason why I'm talking to you about all this is because we know this is mandatory. How many of you guys would have showed up if it wasn't?
Not every day. Not every day. I ain't gonna lie.
Exactly. But then when you're talking about being realistic, a lot of students, I'll tell them right off the gate, it requires 4 hours of studying in addition to your classes every single day, which tallies up to 25 to 30 hours of studying to be realistic, to gain enough information to go to boards and successfully pass with no doubt. If you do anything under those 4 hours, which we know predominantly 90% of the school does, that reduces your chances. So you're not being realistic with what you say that your goal is. This should be the most important thing in your life right now, because this will change your life. Do you understand that? And that's the way you got to look at it. This can change your life. This changed my life. Did I tell you that? This changed my life. I went from a jack of all trades, master of none, to somebody that's in the game, helping other people. This is where I always wanted to be, in a place where I could help other people, where I could tell other people what to do, to not do what I did. Do you understand that? And I'm not talking about studying. Studying, I studied. But I'm just saying, at a late age, you guys got youth on your side. You got a chance. Get that BSN, get that MSN, but it's not gonna happen unless you make a change. Do you understand that? And the first change that you can make, if you think Mr. Decker is full of it, then I challenge you. Between now and taking that board, make a change. And you'll pass the NCLEX. Between now and that board, don't change anything, and you're doing this. Roll the dice. And hope to God. Cross your fingers in your toes. Because that's what you will be doing. All right, so we're in mobility and immobility. So the first thing I want to talk about, okay, is what are the three main spinal abnormalities? The three spinal abnormalities. That's one. Let's start there. Kyphosis, and we know that's a normal part of what? Aging. But kyphosis affects what organ? The lungs. Okay? Does it affect the lung? Everybody do this. I want everybody to try to take a deep breath. Can you do it? So you see where kyphosis, one of the biggest things, if you have an elder adult and they have this major kyphosis, what is going to be the priority for you? Respiratory. Do you understand that? Could that lead to an infection if they can't expand the lungs properly? Yes. Besides hypoxia, it could also lead to infection, right? Okay, what's another spinal abnormality? Oh, we went lordosis? Okay, lordosis. Who do we see lordosis in? And? Others. I've got a lordosis right now. Huh? Boy, it's so funny. You know, he broke my TV, right? He broke my TV. I ain't 2 years old. They would fear me, and I don't want my grandson feared. I was teaching online, and the person watching him was supposed to be watching him, and they let him go in the bedroom. He came out of the living room. He was trying to, do his little baby stuff, and they told him no, go in the room. He said okay. He went right in there in the little toy box, pulled out the hammer mallet thing, went right over to the TV and went bam. Came in and the screen wasn't cracked, but behind it, it had all this, whatever. Oh my gosh, that was such a nice TV. Well, I went and got another one.
Of course.
First thing I did was buy a Samsung. Don't buy a Samsung. Okay, I paid $800 for it. Got it home, put, carrying it and all that crap. Got it all set up, and I was watching sports, and it was just fuzzy as crap. So I had to talk to a student in class that get one of them high senses. Oh, that's a good TV. It was like $300 cheaper. And I got 75 inches instead of 60. I got a high sense, I think it's called high sense. Those are good TVs, guys. But anyway, yeah. So you never know what's going to happen. All right. So we talked about kyphosis. We talked about lordosis, and then we said what? Scoliosis, the abnormal lateral curvature of the spine. What grade do they usually test for that?
14%.
6th grade, right? And it's more familiar in which one, male or female?
Female.
Females. Okay, females. And what are you going to notice when you do the bend test? What are you going to notice? What are some signs that they possibly have that? The signs.
I guess the shoulders on the line.
The shoulders, right? And also the gluteal folds, right? And they're going to walk with a what? Limp. We got that? All right, if we are transferring somebody to the bed to the chair, what do we got to know about that? No, we ain't talking about the patient, the technique. From the bed to the chair. So you want the back of the chair to be towards the foot of the bed. You're going to put it at a 45-degree angle, and you want to make sure that the good side of the patient hits that chair first. Do you understand that? So if I've got a bad right leg, okay, I've got a bad right leg, then which side are you going to put that chair on? Now I want you to think about that. If the back of the chair is near the foot of the bed at an angle like this, and I've got that bad leg on that right side, when you sit me up, which leg is here? That's the right leg. Mm-hmm. So when you stand me up and pivot me, which side's going to hit first? The right. Okay? So you want to put that chair on the same side. If you're doing it from the bottom up, you want it on the same side as the bad leg. You understand that? If you're top down, then it would be the opposite. If you're going from the chair from the top of the bed, from this perspective, then it would be the opposite. But the bottom of the bed, you want it on the same side as the bad leg, because when you sit them up, the bad leg will be on the opposite side. So when you pivot and rotate, the good side will hit first. Do you understand that? Everybody got that? So if it's from the bottom of the bed up, same side. If it's from the top of the bed down, opposite sides. Do you understand that? Everybody got that, or are you just shaking your head? All right, so if I have a bad left leg and I'm doing the bottom down method, which side are you going to put the chair on? If I've got a bad left leg and I'm doing the top method, which side are you going to put the chair on? All right, very good. All right, what are the two types of ADLs? This is fundamentals, guys. So if you've got fundamental stuff, look it up. It's important. You got to know this. Functional and instrumental. Functional and instrumental. What are functional ADLs?
Every day.
Okay, which includes?
Taking a shower.
All right, what are instrumental? Grocery shopping, paying bills, making telephone calls, etc. You understand the difference? Instrumental versus functional. Okay, you got to know that. That could be a question you may see. Why do we do range of motion? This and what? Very good. So enhance circulation and improve joint function, right? Okay. What are isometric exercises? Isometric exercises. What are those? The muscles, while keeping the joint stabilized. That's the importance of that. If you have a joint issue, but you still want to make sure you don't get contractures in the muscles, then what type of exercises can you do? Right, because it won't affect the joint. Do you understand that? Okay, if they're not able to bend that joint, right? But you still want to make sure that you're getting exercise to those muscles, then what type of exercise are you going to do? Does everybody understand that? Okay, so if you got a patient in a cast, what would be the perfect type of exercise? Right, because they can't move the joint, right? What are the risk factors of immobility? All right, let's start there. Pressure injury. Not the blood clot's not an answer, it is DVTs, right? But immobility leads to decubitus ulcers. Untreated decubitus ulcers can lead to what? Osteomyelitis. But what did we say were the complications and the risk factors of immobility? Decubitus ulcers, and decubitus ulcers can lead to what? Osteomyelitis, which is what? Infection of the bone. Okay. So what can we do as interventions? A minimum of every 2 hours. What else? Huh? Pad the bony prominences, so use elbow and heel pads. What else? Range of motion. What else? Air mattress. Raw sheets. Try to ambulate them as soon as possible. Okay. What about sensory impairments? Isn't that also a complication of immobility? So you have to provide some type of stimulation for the patient, right? What kind of stimulation could you provide for somebody that's immobile? Huh? I can't hear you guys whispering. What?
Music.
All right, music. What else? You're going to keep reorienting them? 60 to 90. High Fowlers. What is high Fowlers? 60 to 90. High Fowlers is what? Well, you get to do it again. Does everybody got that? Normal Fowler is what? Just Fowler. 45 to 60. 45 to 60. Semi Fowler? 30 to 45. And low Fowler? 15 to 30. 15 to 30. Okay, do we use Trendelenburg anymore? No, because it affects breathing. They use modified Trendelenburg. Somebody look up modified Trendelenburg. Modified Trendelenburg.
Laying a patient flat on their back with their legs slightly elevated, but without tilting the head or body.
What does it say?
Laying a patient flat on their back with their legs slightly elevated, but without tilting the head or body.
Everybody got that? Modified Trendelenburg. Okay. You guys know what a tilt table is?
Yeah.
What is a tilt table? What is the purpose of a tilt table?
Are you talking about like an operating table?
A tilt table. It provides weight bearing on long bones and helps prevent decalcification of the bone. It also helps the patient who is flat for a long period. A tilt table. So if somebody's in traction, they may be in have a tilt table. Do we understand that? Okay. And if they are on a tilt table, it's going to be between 5 and 10 degree increments. And you need to know that you need to monitor the blood pressure while they're on that tilt table. Very big. Any issues with blood pressure or pulse, you stop. So any dizziness, any pallor, any tachycardia or hypotension, you stop. The tilt table. We got that? Do you know what a tilt table is now? And do you know what you need to be worried about when a patient's on a tilt table? Excellent. Heart rate, blood pressure, right? And you know the signs and symptoms let you know that there's an issue? Dizziness. Okay, very good. Pallor, very good. Okay. Now, let's talk about them crutches. The height of the crutch should be what? The height of the crutch should come to where?
Like 3 inches below your armpit.
2 to 3 finger breadths below the axilla. 2 to 3 finger breadths below the what? Why? You do not want to bear weight on the axilla. Why? Everybody look up nerve palsy. Nerve palsy. Look it up. Nerve palsy. Or crutch palsy. Crutch palsy. Look it up.
A nerve injury caused by prolonged compression of radial nerve, often due to improperly used crutches.
Everybody got that? Everybody understand that? Are you pulling my pellagra? Huh? Where should you put the weight when you're using the crutches? Where do we put the weight if we can't put it on the top of the crutch? Hand grips. What type of flexion should you have in the elbow in relation to the hand grips? 20 to 30. Then you have external radiation. What's the biggest thing here? External radiation. What's the biggest thing here? Skin. Where they're directing that beam of radiation through the skin. You got to keep an eye on that skin. What does that skin do? Yes. Big time. Desquamization. Look up desquamization. Look it up. Radiation. Desquamization of the skin. Look it up. What does it say there?
The natural process of body shedding dead skin cells from the outer layer. That's all right.
Yeah, but look that up along with radiation therapy.
Reaction that can occur after radiation therapy, characterized by the peeling or shedding of skin, often accompanied by weeping and potential open sores.
And we got to tell them not to wipe off that temporary tattoo, right? So they wouldn't use washcloths and powders and all that on it, can they? Should use your hand, right, to clean it. And you got to avoid the sun, don't you? And up to a year after the radiation therapy, you know that, right? Because of the desquamization. Everybody got that? Now look up ARS, acute radiation syndrome. Acute radiation syndrome. Acute radiation syndrome. Look that up. ARS. And look at the three main organs that affects, which I believe is the skin, GI, and heart. Look that up. You see that? What is that? Do we see it? What do we see? Oh, I'm about to find it for you. I'm about to show you. Hold on. And you know what? We're going to do this. We're going to do this, and then we're going to do that. Matter of fact, you know what we're going to do? We're going to take a break first.
The heart, GI, and bone marrow.
Ah, I was wrong. Heart, GI, and bone marrow. Heart, GI, and bone marrow. I had one off. That's why you got to do the CBC. Because it causes bone marrow suppression, and you got to keep an eye on that. If they got the bone marrow involvement, you got to do repetitive CBCs like every 2 hours because it can deplete the red, the white, and the platelets. All right, let's take a break. It'd be 3 o'clock right now if we just took lunch at 1. It'd be 3 o'clock. It'd be 3 o'clock.
But you we can say lunch again. You gotta it be the same people every time. It be the same people every time.
But
That's when you go back. Why you can't go get you no food? That's what y'all ain't use y'all phones this morning.
okay. All right.
You wanna listen to
All
oh, no.
right. Things go through my mind. It's just that you can't. This is a private school. You can't do but so much. You understand what I'm saying?
That's why I said, oh,
first. Increase the flow rate. Okay? You want this? What kind of exercises do you teach post prostatectomy? What? Did you say Kegel? Oh. It's close because you're going to have them start and stop the stream of urine because dribbling is a common but temporary problem afterwards. So they're going to start and stop the stream of urine. Well, I wouldn't call it Kegels. Just call it stopping and starting the stream. And please don't call it Kegel for me. Okay, that's the same difference. Will the post-prostatectomy patient be impotent? With that perineal one, yes. The most radical form, which is the perineal prostatectomy, yes. They will be impotent. Got that? But if it's not the radical type, then no. It's just a regular TURP. How often should the drainage bag be emptied on a Foley? Huh? What? That wouldn't be realistic, right? At least every 8 hours. Okay? What is the most common problem due to catheterization? UTI. What is the most common organism for UTIs? E. coli. What is the most common route for organisms to enter the bladder when catheterization is used? Up through the inside of the catheter in the days following catheterization. What foods make the urine acidic? So,
Carbonated.
cranberry juice and apple juice. Okay, avoid citrus juices, they make it more alkaline. What is important about the level of the urinary drainage bag? Lower than the bladder. Okay, how is the catheter taped in a male? Lateral thigh or abdomen. And how is the catheter taped in a female? The upper thigh. What urinary pH prevents UTIs? So acidic. Acidic, because the range of the urine, it could be either slightly alkaline or acidic. So they want you to know the more acidic you make it, the less chance of getting an infection. Should the drainage bag ever touch the floor?
No.
Is it okay to routinely irrigate the indwelling catheter? No, not routine.